Well, good evening, everyone. My name is Sean Suda, and I welcome you to the SAGES webinar on surgical guidelines during the COVID-19 pandemic. We know this is a challenging time for everyone, so we appreciate your attention, and we hope that we can provide some insight that will help you navigate through this current public health crisis. We have an excellent panel today, and I'll be introducing them as we go along. Here are some disclosures. This is a CME activity, so SAGES designates this live and recorded activity as 1.5 AMA Category 1 credits. If you're registered, you'll be receiving an email with a few questions and instructions on how to claim your credit. The objective of this webinar is for learners to be familiar with the content of SAGES statements and recommendations, and will be better prepared to implement SAGES recommendations in their own institutions. These are the topics we'll be covering today: rationing of services, guidelines for surgery, practical measures for surgery and endoscopy, the SARS-CoV-2 virus and filtration, N95 masks, critical care and mechanical ventilation, telehealth, and a few words from our current president, Dr. Asbun, and moving forward. We will be leaving 5 minutes after each presentation to answer questions, which you can submit via the chat function on your Zoom menu. We won't be able to answer every question, obviously, but we will be posting a frequently asked questions and answers on the SAGES website in the days following the webinar, so keep your eye out for that. Now, I would like to introduce the SAGES immediate past president, Dr. Aurora Pryor from Stony Brook University in New York. I think I speak for the entire SAGES family that we've all been very indebted, inspired, and very grateful for the leadership that Dr. Pryor has provided during these trying times. Dr. Pryor.
Thanks, Sean. If you can end your screen share, I'll take over. Well, thanks everybody for joining us tonight. This webinar on recommendations about COVID-19 is a big deal for us. I was honored to lead SAGES as we came into the pandemic, and once again, I'm impressed with the response and enthusiasm of many of our SAGES leaders to help address education and fact-finding relevant to this crisis. So for those of you who aren't super familiar with SAGES, we're over 6,500 members. Our vision is to improve surgical care and reimagine it for a healthier world. Our mission is to innovate, educate, and collaborate to improve patient care. Probably you remember, although it's been a whole month, that we were planning our SAGES meeting to be in April last week. Unfortunately, a lot of things changed between early in March and early in April, namely COVID virus came along. The first thing that we realized that this was going to start to impact us was when the K-Cells meeting was postponed in February. We started getting emails early March from US people who were having issues with COVID. This came from NYU when they closed down their progress, and we had faculty start to pull out of SAGES. We then had a debate. What was going to win? Were we going to be able to have our meeting? What was going to happen moving forward? And unfortunately, in March, we decided to delay the meeting, which turned out to be the right decision. And so hopefully we'll see all of you in August when we reconvene for the SAGES 2020 Congress. In the meantime, a lot of fear spread about coronavirus and the implications. This was on Facebook, social media, Twitter sites, and people started to get concerned about laparoscopy. And was this something we could really do, or should we not be doing laparoscopy? And we realized this was a spot where we could really help add from a SAGES background and SAGES resources and education. So these are our SAGES committees. We have a lot, but we started by tapping into these committees to use our resources, including our Quality Outcomes and Safety Committee led by John Dort, who's on our panel tonight. We pulled in some of our other groups as well, acute care and advocacy. Moving forward with some of the other groups, community practice with our expert on telehealth and patient care, TAVIC, or Technology and Value Assessment, which is led by Sean Suda, the Technology Council, that's led by Chris Schlachta. Other groups moving forward, Educational Resource, led by Dean McCamey, who's also on the call tonight, and a variety of other groups, including our executive committee. And these groups together really looked at our SAGES resources, including people, to pull together some of the things we could do. We grouped in with Facebook and publications and are moving forward and actually are going to publish some of our recommendations in surgical endoscopy. We've also grouped with our oncology task force and Fuse, which are going to start to put some of these writings into long-lasting statements as well. In addition, we've worked out with our research group and are now going to have some grants relating to COVID. So you may hear about this and may apply. Those are going to be due in another month. We've also worked with our ethics group, who now wants to talk about some of the ethics of COVID surgery, alternative funding about reaching out and trying to get some resources for SAGES, and really things that we can do across the society to move forward with this initiative. In addition, we've partnered with other societies, including the European Association for Endoscopic Surgery, to take their advice as they were leading us in this initiative. So we came out with SAGES and EAES recommendations, initially SAGES alone on March 19th and subsequently with EAES on March 30th, and have a new page on the SAGES website, which you can reach at www.sages.org/category/COVID-19. You can also find that by rolling down on our main page. In addition, this initiative led by Horacio Osben, our new president, was trying to pull in those members from Europe, and we still have a weekly meeting trying to come up with recommendations for best practices across the globe in COVID management. Resources we have developed were surgical rationing, MIS and open recommendations for surgery, endoscopy, telehealth, PPE and N95 reuse, ventilator management, smoke evacuation and filtration, cancer management, and links to some other sites. Again, these are going to be published in surgical endoscopy. Tonight, we are taking some of these best practices recommendations and really want to share them with you. These are the people who invented these documents and resources for SAGES and are really true leaders for us. This is not something that one person could have done alone, but really represents how our society works together to innovate and move quickly. And I thank all of them for their participation in this initiative. I look forward to hearing from Jonathan Dort, Debbie Keller, Chris Schlachta, Dino Spaniolis, Dean McCamey, Eugene Cho, Viola Wong, Sean Suda, Rob Lim, Michael Cripps, Kevin Wasco, Caitlin Calvert, and additionally Horacio Osben, our current president. So thank you all of you, and thanks for having this amazing event tonight.
Thank you, Dr. Pryor. As we get ready for our first presentation, I want to thank the companies for their generous educational grants in support of this activity, CONMED, Ethicon, and Medtronic. Our first talk is Rationing of Services and Practical Guidelines for Surgery. This is by Jonathan Dort, who is Vice Chairman and Program Director at Inova Fairfax in Virginia. He's Chairman of the SAGES Quality Outcomes Patient Safety Committee. And co-chair of that same committee, Debbie Keller from Columbia University Medical Center in New York. Now, Debbie has been on the front lines of this pandemic in New York City. She's a little under the weather. She did help us put this together, but Jonathan will be speaking on her behalf. Jonathan?
Thank you, Sean. Can you hear me okay?
Yes.
Okay, great. Thank you for the introduction. And as you mentioned, Dr. Keller prepared this with me, but she is still recovering her voice, so I'll go ahead and present it for both of us. We are indeed in a pandemic, and pandemic is defined as a disease that is prevalent over a country or the whole world. The origin of pandemic is Greek. It's pan for all and demos for people, so it literally means all people. We're gonna try to put forward some strategies to prevent that from really happening, but unfortunately, we are in the middle of one, and it was designated as such by the World Health Organization on March 11th, a date which now seems like it was many years ago, not weeks ago. And it's unlike anything any of us have experienced or hope to ever experience again. While we've trained hard to become skilled surgeons, most of us are at best only amateur virologists and epidemiologists. Even so, we've all been tasked with developing and implementing a comprehensive and coordinated plan on how we deliver care, to whom and when we deliver it, and how to do it in the safest way possible to both patients and providers. There is one surgical skill that we can utilize to accomplish this, and it's namely the ability to assimilate, review, and process the full amount of information and data available to us, and to make decisions based on that body of information and execute actions based on those decisions. That's what we've tried to do here. So let's talk briefly about some facts we do know about this virus. It is in the family of coronaviruses. It has an average incubation period of 5 days, and about 98% of patients will develop symptoms by 12 days of the ones that are going to develop. However, the virus can and does spread in the asymptomatic phase. And this is obviously a significant fact when it comes to containing spread, and specifically for our purposes, this is it's critical to preserve this health and safety of our surgical teams. Not only because they deserve to be protected, but we need a surgical workforce moving forward, and we need to make sure that that exists. There are some reports that there is a light at the end of the New York tunnel, but most everywhere else in the US are still on the ascension of the curve. Contingency planning clearly can't start at the time of crisis. It must start on the flat early part of the curve. Plans for staffing at each stage of contingency must be worked out, and it may include personnel at all levels being redirected to the care of critically ill COVID-19 patients, sometimes requiring ventilator assistance, which may be considerably outside of our normal practice patterns. Reviewing that information is necessary, and it's part of one of our later discussions. The logistics of how many and which operating rooms will remain functional and who will staff them needs to be planned. Many hospitals in the most severely affected areas have already had to convert operating rooms to overflow ICU rooms. Rooms with the right facilities and the right protections need to be planned for, and that will also be covered in detail in a subsequent segment. Segregation of known patients, known positive patients, must be arranged as well, and a plan for triage of outpatient care, including the triage of who gets seen and how they get seen, is also necessary. It is absolutely necessary that all elective and surgical and endoscopic cases be postponed during this crisis. While this does place a financial burden on every hospital and surgery center that can be significant, the necessity to protect both your patients and your staff from unnecessary exposure, the need to minimize the unnecessary use of valuable personal protective equipment, and the ability to keep rooms open for only the truly emergent cases mandate this step for all of us. The tricky part, of course, is how do we define what's an elective case? What counts? Bleeding, perforation, strangulation, infection, they would all seem to count. But how long do you make a cancer patient wait? Are there other treatment strategies that should and can be considered? The SSO has published a set of COVID-19 guidelines, and other organizations are starting to do the same. The same questions exist in general surgery. If your operating rooms are being converted to ICUs at an increasing rate, should appendicitis and cholecystitis be treated non-operatively with antibiotics? For hernia repairs and other elective procedures, pain alone may have to mandate a postponement. Systems, hospitals, and departments all have to start making algorithms for the care of these patients. Transmission is all about exposure. Non-essential staff, which can include administrative staff, research staff, education staff, quality staff, and clerical staff, should all be allowed and encouraged to telework as they are able. This is true for hospital and university department offices for both inpatient and outpatient areas. Convert all outpatient clinics to video or audio visits. Only patients with urgent issues that require a physical exam should really be seen in the office. All other patients should be seen by a telehealth visit, and all non-urgent visits should be postponed as well. A review to how best utilize manpower for telehealth visits should be done by each department and each hospital. Some hospitals rotate teams between inpatient and outpatient services to allow breaks from the constant intensity of the inpatient service. Some departments and offices utilize healthcare providers whose age or medical conditions make them too high risk to deploy in the inpatient environment and can maybe be used to serve these telehealth services. All other non-essential activities should be canceled or converted to a virtual platform as well. For many of us, surgical education is in our DNA, but times demand that changes be made, and big in-person meetings just can't exist. Doesn't mean they have to be abandoned. Many academic programs have successfully changed the didactic sessions to a virtual format. Additionally, many organizations and groups offer online education through webinars, videos, and social media platforms. SAGES has a full menu of educational offerings, including webinars like this one, Facebook groups with online didactics in multiple specialties, and a full video library. Equally, clinically necessary multidisciplinary meetings can and should be transitioned to a virtual format. In many cases, it's important to do so. They're necessary for patient care, patient triage, patient disposition, and most certainly for the very planning sessions on the disaster preparations that we're advocating for. This next slide is going to be a very difficult pill for all surgeons, but specifically surgical educators of all varieties to swallow. In a situation such as the one we're in, every exposure produces risk. All clinical interactions need to be reduced to the minimum mandatory personnel. This includes the operative or procedural team. This is not a time to be teaching techniques or to have students or other non-essential learners present in the room. Equally, inpatient visits for rounds or consultations should only be visited by the decision makers inside the room. This includes the pre-op area where repetitive visits by multiple providers should be avoided. Again, all of these recommendations are made on the basis of reducing risk by reducing exposures and minimizing the needless use of valuable personal protective equipment. Same principles apply to our research teams. All research activities, including meetings, new patient enrollments, or any other in-person activities, should be suspended or converted to a virtual form. The one exception to this would be studies related to better understanding this disease that we have only had a few weeks to grasp. Studies aimed at understanding its biology, predicting its behavior, or determining its treatment strategies should be encouraged. The collaborative you see on the screen is one such study, COVID Search, whose goal is to gather understanding of how this disease affects outcome in surgical patients. So we now start to dive into more specific strategies related to how surgeons should address this virus clinically. There are some broad assumptions we're going to have to make. We're all still learning a lot about this virus. There's very little evidence to go on to make forceful recommendations or deliver standards of practice in the surgical environment. We know that this disease is primarily a respiratory disease. We have data from previous studies showing that the presence of viral particles exists in surgical smoke. These were other viruses which have different transmission modes and cause other diseases. But that leaves us with one of two pathways. Either we wait for studies showing those same properties in this coronavirus, or we assume it has those properties, and we make all of the subsequent precautions and suggestions based on that assumption. I think it's clear to all of us which approach is necessary to ensure the safety of the surgical team and the minimization of the possibility of transmission. So let's start with the first question. Dr. Pryor alluded to it. This is a society of minimally invasive surgeons. Should we be offering our patients minimally invasive surgery? The answer is a strong, it depends. If we make the assumption that this virus can live in surgical smoke and be transmitted by that mechanism, there are arguments to be made both ways. Surgical smoke and a pressurized pneumoperitoneum certainly would increase that risk with its uncontrolled release into the room under velocity. However, an equal argument could be made that the sealed abdomen allows better control of the smoke with utilization of evacuation considerations you're going to hear about in the next segment. Also, if a minimally invasive procedure turns a one-week hospital stay into a one-day stay, the lessening of the length of stay and utilization of that bed for patients that need it, that element needs to be considered in the decision as well. Therefore, the recommendation we make is to consider MIS procedures in the right clinical circumstances, but with the right precautions for smoke evacuation, and that's going to be discussed shortly. This assumption should then drive all of our intraoperative decisions. We need to provide and then mandate the appropriate use of PPE for all team personnel. We've seen a significant amount of public material concerning what constitutes appropriate protection, and a subsequent segment of this webinar is going to dive into those details. Equally, every aspect of the operation, starting with and most importantly, the intubation and extubation has to be addressed. And again, specific strategies around the handling of that is going to be covered in the next segment. So which patients should we be taking these precautions? Ideally, patients should all be tested prior to going back to the operating room. Testing for this virus becomes more efficient and more available every day. If you have a quick and reliable testing mechanism available to you, or if the patient status is already known, great. Use that information and base your decisions on it. But when you're taking a patient back to the operating room whose status is unknown, the most abundance of caution would dictate that you treat those patients as if they're positive. A lack of symptoms and a lack of a concerning history in no way rule out the presence of this virus. The stakes of being wrong are just way too high. So finally, I just wanted to reiterate what Dr. Pryor said and show you a quick slide of how these recommendations that I just went through get created. The team, which is call our rapid response team, tackles these clinical process or practice questions. We take all the information that we can find about it, assimilate it, and put it out there. It is difficult in the world of a lot of misinformation, which can sometimes be almost as virulent as this virus, to sort out what is real, what should be passed along, and what should be contained within these recommendations. And finally, it goes through us and then through the Surge exec, through the SAGES exec, SAGES board, and then out in publication. We call it a living document because the information is coming at us fast and furiously. We want to stay up to date. We want to give you accurate information, but we want to get it to you in a timely manner so that you can act on it as we approach the high part of this curve. Thank you for your time and attention. I'm happy to look at any questions.
Thank you, Dr. Dort. We do have some questions coming from our audience, and I invite yourself as well as any of the panelists to give their insight. So one question is, even if we have a patient with a known status of being COVID negative, given the high false negative rates, should we take every precautions that we would normally do for a COVID positive patient?
That's a great question, because I think we're still learning and establishing what those rates of false negative and false positive are for each of these tests. If you, there's certainly, if you have the personnel for it and if you have the equipment for it, certainly take every precaution that you possibly can, and that's going to be the safest possible route. I think most places are getting to the stage where they have to start taking those supplies into consideration, and then you have to start looking at using the supplies in the absolute most cautious areas and with patients who either you don't know the status or you know it to be positive.
Now, there are a couple of questions that regard testing every surgical patient preoperatively for COVID-19. And someone makes the comment, Stefan Schultz here, that that's far from reality at this time. We know that in many regions, testing isn't done unless it's specifically going to change management. So given that, should we just assume all patients are positive?
I completely agree. And I don't think anyone is at the stage where they have that luxury of having a rapid and completely accurate test to be able to make those definitive distinctions on. I think in lieu of that, we all have to treat every patient going to the operating room as if they're positive. Part of our screening has always been to define something as high risk. And we've based it on patient history, we've based it on symptoms. But if you're going into an environment where droplets are coming at velocity to a team, that automatically counts as high risk. And I think, therefore, we have to exercise the caution to say that if you don't know the status, treat the patient as if they're positive and use all the precautions you're going to hear about in the next few segments.
We have a minute. Any questions from our other panelists, Dr. Mikami or Lim?
Yeah, so, I think the best advice we can give you now is when you are in the operating room and you're doing a laparoscopic operation, if it's a non-COVID patient, it was tested negative or has no symptoms and no exposure, you should practice best scenarios and best practice. When you do a laparoscopic case, to try not to leak any CO2 gas out of that patient, because when you do operate on a COVID-19 positive patient, you want to have the experience. So starting today, every time you do a semi-elective laparoscopic operation, practice what we're going to talk about today. So when you do operate on that COVID positive patient, you're ready for it and your team's ready for it. I just did a case yesterday where we tried to do minimal CO2 leakage from our laparoscopic case. It took everybody 2 or 3 extra steps to get the procedures right. So practice now. So when you do have those patients that come in, you'll be ready for those patients.
And thank you, Dr. Mikami. We have a lot of questions about the specific techniques, as you alluded to, during laparoscopic endoscopic surgery as well as open surgery. So this leads right into our next topic, which will be practical measures for surgery and endoscopy. Presenting are Dr. Christopher Schlachta, professor in the Department of Surgery and Oncology at Western University, London, Ontario, Canada. He's currently the SAGE's vice president and chair of the Technology Council. With him is Dr. Dino Spaniolis from Stony Brook University in New York, who is co-chair of the SAGE's Quality Outcomes and Patient Safety, as well as the Research and Career Development Committees.
Thanks, folks. So I'm going to start first. If you can see my screen, we're going to talk about the practical measures for surgery and endoscopy, and basically how to do surgery and endoscopy more safely. We're going to cover surgery in general, but then talk some specific points about laparoscopy and endoscopy. This is a slide that Dr. Dort just shared with you. These are the 8 points that we had placed in our very first SAGE's document about COVID-19, and I'm going to cover some of those points. I don't think I need to dwell on the importance of getting informed consent from your patients and understanding that they're having surgery under exceptional circumstances with exceptional risks. The issue about testing, we've just debated. I think we don't need to go over that again as well, other than to say everybody's going to have their own approach to how they handle testing, and it really depends on where your bottleneck is. In some institutions, it's access to testing that's holding testing back. In other institutions, it's lack of PPE, and therefore the desire to test everybody in order to be able to perhaps relax some of the intraoperative PPE requirements if you have somebody who's tested negative. The issue then is, of course, what's been discussed about false negatives and can you trust a negative test, and what's the appropriate time frame for a negative test. In our institution right now, we're using testing within 24 hours. And basically, we're assuming that everybody has coronavirus unless they have tested negative within 24 hours. Dr. Dort alluded to airway management precautions. Obviously, we already know that the coronavirus is infected in the respiratory epithelium, and so any procedure involving the airway is going to potentially aerosolize virus particles. Our SAGE's recommendation was to make sure intubation, extubation takes place within a negative pressure room because of that high risk of aerosolization. You want to have only the airway management people in the room at the time. You don't need any extraneous people in the room. And then either you want to do that in a separate room, hence the negative pressure room if it's available, but not every institution has that. The other option is you do your intubation and extubation in the COVID operating room, but again, with only the essential personnel for the airway procedure, and then you have a mandatory waiting period, which is quite variable depending on institution recommendations, from 10 to 30 minutes, but you should have an institutional standard to say once the tube is in, you wait that mandatory waiting period, and then the rest of the surgical team can come in the room if you don't have the ability to use a separate room. Obviously, you want to have dedicated ORs for your COVID patients. Again, we're treating everybody who hasn't tested negative as a suspected positive case. Again, a negative pressure room should be considered if it's available, but bear in mind that many infectious disease specialists will tell you that a high air exchange rate in the room is actually more important than negative pressure, as long as you're doing something to be careful about leaking the air out of the room, like enhancing the door seals and so on. But if you can get a room that exchanges its air 20 times per hour or more in a HEPA filtered room, you're actually going to do a good job of protecting all of your surgical staff as well by constantly filtering and recirculating the air. I would suggest that when you're picking your COVID operating rooms, that you plan your traffic routes carefully to minimize the distance that the patients have to travel, risk exposure to any bystanders, and risk the chance of contacting any items that'll become fomites for spread later on. And then you want to make sure that your operating room has a minimal amount of equipment in it. So these are not going to be your standard operating room. If you're going to have suture racks and so on in the room, make sure they're covered. Make sure that the surgical team leaves everything outside the room that isn't necessary for the operation, including pagers and cell phones and so on. That should all not come into the operating room. That might be a change in practice, but we learn as we go along. Dr. Dort has already talked about making sure you only have essential staff in the room. So that includes making sure that your nurses are aware that they're not going to be leaving in the middle of a case for a break. And then the whole issue of resident training has come up, and I think I quite agree with the notion that we've probably suspended training right now in the interest of this pandemic. I would suggest we're all familiar with doing a preoperative checklist and the pause. Consider having a preoperative huddle before entering the room where you have all members of the surgical team present so that you can talk about before the patient even comes to the OR. What are we planning to do today? How are we planning to do it? How long is it going to take? That'll help your nurses organize who's been on break and who hasn't been on break, who's nearing end of shift, and so on. What equipment do you need in the operating room? Because you want to limit the amount of time the doors are opening and closing and people are coming and going. So don't just use a standard pick list. Go over it as part of the huddle before the surgery to make sure you know exactly what you need. And then obviously it's a part of the checklist anyways, but have a clear discussion about what the disposition of that patient is going to be at the end of the surgery. Are you recovering the patient in the operating room? Are they going to a COVID area in your post-anesthetic care unit, or are they going to go back up to the floor? All important considerations. We've talked about PPE for the staff. Once again, I think if you can reliably test the patients to make sure that they're negative before surgery, you can probably just drop down to our usual droplet precautions. You've got to decide for yourselves whether you trust the concerns about false negatives right now. But basically, it's a pretty safe thing to say if the PPE is available, assume everybody has coronavirus. And I strongly agree with the notion that you should be practicing. Even if you have somebody that has screened negative, still practice for the time being that they're a coronavirus patient, because there are a lot of things that are easy to say, but then when you try to enact them in the OR, you realize they're a lot more difficult than you thought they were going to be. This is a graph that my co-speaker obtained from the CDC about donning and doffing procedures. It's important that every institution have a very clear protocol for donning and doffing. We all learned in medical school that if you learn how to do a physical exam exactly the same way every time, you're going to do it right every time, and you're not going to forget how to do it. I think it's important to have a very clear, don't make it up on the fly protocol for donning and doffing your PPE. It's a good idea to have a partner with you. A lot of people become contaminated by just simply their donning and doffing procedure alone and not necessarily directly from the patient. These procedures are all designed for healthcare providers who are not necessarily scrubbed in the OR, and you are going to need to make a few modifications. For example, this procedure shows you putting on the gown first. You know, of course, that what you will likely do is put on your mask, put on your shield, put on your cap, then you're going to go and scrub. One change that we have made is to everybody wears 2 pairs of gloves, which I do anyways, but I put on my inner pair of gloves before I put my gown on. Then I put my gown on, then I put the outer pair of gloves on. So that when it comes time to doff my attire, while I'm still in the operating room, I can take the gown off, roll it up with the outer pair of gloves to avoid contamination, and then I still have a clean inner pair of gloves on that I can use to take off my visor, my cap, and my mask. I will point out that you want to make sure you check your gloves, of course. If you've had a hole in your outer layer, then you need to discard the inner layer and then clean your hands and carry on as you would otherwise. At this point, I think I've probably used more than my time, and I'm going to release my screen share and hand it over to Dino, who is going to take over from me. Have I succeeded in releasing my screen share?
Yes.
Okay.
Okay, let me take it over. Thank you for all the information.
Dr. Spaniolis, are you coming online, or do you want me to carry on?
Yes, let me pull it up. Can you see my screen?
We're on. There you go.
Yes.
All right. So restricting electrosurgery use is recommended to minimize particle and aerosol formation. A lot of this evidence comes from some research on other viruses, but we've extrapolated that into this until more information is available. Units should be set to the lowest possible setting for the desired effect. And when doing open surgery, cautery pencils with attached smoke evacuators should be used. In terms of cleaning equipment, the statement calls for separate process for instruments used on COVID patients. And this is particularly important about the handling of the instruments between cases, in addition to the cleaning part. So if you have instruments just used on a COVID patient, it is worth flagging those trays so that they can be handled appropriately and separately to minimize contamination during that processing. Specifics to laparoscopy that will be discussed have to do with minimizing gas leakage into the operating room. Incisions for ports should be as small as possible to allow for the passage of trocars, but minimizing any leakage around the trocars themselves. So the purpose is really to have a secure overall seal around the trocar. Appropriately sized incisions are part of that concept. Minimizing slippage of trocars is also part of that. Balloon tipped trocars may be of help. Trocars with threads or even suturing of the trocars themselves. All these things can help to get a better seal and avoiding a trocar moving in and out or falling out during an instrument exchange. The insufflation pressure should be kept to the minimum that will allow for safe exposure. And that really has to do with the higher the pressure inside, any small defect in the seal would lead to CO2 leaking out into the operating room. All pneumoperitoneums should be evacuated via filtration system before closure, trocar removal, specimen extraction, or conversion to open. And we will hear a lot more detail on this in the subsequent presentation. In terms of endoscopy, some of the elements of the statements provided on the website are common with surgical procedures, namely the use of PPE, minimizing energy application if possible, and then the cleaning and handling of equipment that were used for COVID patients. Some specifics to endoscopy are listed here. Since COVID can and does frequently present with GI symptoms, any emergent or urgent patient undergoing endoscopy for evaluation of such new symptoms should be considered high risk of having the virus. Particularly detailed to keep in mind during endoscopy is that caps, if not installed properly, can leak gas. So one should be particularly aware of that, check prior to starting and being very cognizant of this during any procedures through those. Additionally, some endoscopic procedures that can require additional or very extended insufflation should be avoided for now until we have a better understanding of the details regarding the virus and its properties. If this was mentioned during the comments as well, but I think a huge part of getting ready to address these issues is to figure out what of the above works best for you and works best locally. I don't think everything mentioned today may have a role in your institution and practice, but everyone should look how to best apply these elements within their realities and resources available. Another point that is important is that we have to practice, and we have to do this ahead of time. Dr. Mikami mentioned about practicing on a non-COVID patient, figure out the processes and the equipment needed. And then during practice on a non-COVID patient, you may uncover issues with personnel or equipment or some other resource that can and should be addressed before doing surgery on a COVID patient. This also makes the staff more comfortable with the whole process. And that's the part of our presentation for
Thank you very much, Dr.
the details.
Spaniolis. We're getting a lot of great questions, and if you check the chat, many of our panelists are answering them in real time. In the interest of time, we're going to move on to the next topic. One quick question, though, that I haven't seen addressed. For those of you on the panel who do robotic surgery, what are your thoughts in those cases where you normally would do them in patients during this period of time?
Yeah, so I would, again, take as many precautions as you can. I mean, obviously, with the older robotics platforms, sometimes taking the camera out or adjusting, you have to take that seal off, and that would have to be avoided. Maybe allow for more time to do the case, but and desufflate in between times when you have to do that. Probably the best advice I would give is practice, like Dr. Makami said, and desufflate, a few times, get used to doing it so that when you open up that port or to open up pick up the port of incision, there's very little leakage.
Yeah,
Thank you.
I would say, since the surgeons aren't at the table, you really have to make sure your assistants really know the dangers of that CO2 gas coming out and everything. So you really got to train your staff. It's not like where we do laparoscopic surgery, the surgeons are at the table. You're going to be at the console operating, and you're not going to be able to see what's going on with the port. So that's something that you really need to take into consideration when doing robotic surgery.
Yeah,
Thank you.
I would echo that. It takes a lot of attention to avoid any gas leakage, a lot more than you are accustomed to. And part of the practice, really has to do with double checking, have all these mental checks before you do really anything. And that may be hard to do, at least in the beginning, when you're away from the patient.
So
Okay.
just one thing I want you to consider when you think about this is that obviously we worry about aerosolization in the pneumoperitoneum. The other thing with the robot is, could it possibly act as a fomite for transmitting aerosolized virus to OR staff who are moving it around? So I would strongly recommend that any OR staff treat the robot, even the components that are not sterile, the parts that they may be moving around, like they have to expect that it might be contaminated.
Thank you. Absolutely. For our next talk, SARS-CoV-2 virus and filtration, we have Dr. Dean Makami, Professor and Division Chief of General Surgery and Associate Program Director at the John A. Burns School of Medicine at the University of Hawaii. He's also Chair of the SAGES Educational Resource Committee. And Dr. Eugene Cho, Partner at Franciscan Surgical Associates at St. Joseph in Tacoma, Washington, and he sits on the Technology and Value Assessment Committee of SAGES.
All right, thank you very much, Sean. So we're going to go through this hopefully in the next 10 minutes. So there's a lot of information with the SARS-CoV-2 virus. So what it is, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is an RNA virus that has a size range of 0.06 to 0.14 microns. So this is a very important number to remember, because when we talk about filtration, we're going to use microns throughout our entire presentation, and that's going to be the key factor on the filtration products we want to use now. So COVID-19 is actually the disease that results from the SARS-CoV-2. But SARS-CoV-2 has been found in multiple places: the nasopharynx, upper respiratory tract, lower respiratory tract, the entire GI system from the mouth to the rectum, saliva, sputum, throat, and nasal swab, blood, bile, and feces. So it is definitely all around us when we operate. So this slide is used to demonstrate the size of the novel coronavirus SARS-CoV-2. It's a 0.06 to 0.14 micron virus. When you compare it to other viruses, and the reason we put this up is all these viruses have been shown in studies to be transmitted through surgical smoke. So when you look at the sizes of the virus, hepatitis viruses range from 0.02 to 0.06. HPV virus, 0.05. Many studies have been done on HPV viruses and how it can be transmitted through surgical smoke, and actually found on surgeons after infecting surgeons. HIV viruses, also the influenza virus. And when we think about the spread of the virus now, the influenza virus is a very large virus compared to the SARS-CoV-2 coronavirus. It's 10 to 70 microns in size. So how was SARS-CoV-2 spread? So basically it's spread through three primary mechanisms. The most common is respiratory droplets produced when an infected person coughs, sneezes, or now we know even talks. So the virus is suspended in respiratory droplets. So that's the key. When you're in the ER seeing patients and they're coughing, the saliva and the virus is in one particle, that's when our surgical masks and N95 respirators can reduce the wearer's exposure to the airborne particles. Transfer of the viral particles after touching contaminated surfaces is also another route of transmission. And the third route that we're investigating right now, and this entire series is based on, is aerosolization of viral particles. So currently there is no research or data on the transmission of SARS-CoV-2 via surgical smoke. However, other viruses are known to be transmitted through surgical smoke. So in general, filtration information. So filtration may be an effective means of protection from the release of virus during minimally invasive surgery and endoscopy. An N95 respirator is designed to filter out 95% of particles that are 0.3 microns and larger. So we talked about the coronavirus being 0.06 to 0.14 microns. So the key on these respirators is you want that respirator very tight on your face. The leakage around your mask is probably greater than 0.3 microns, so you want to get that very tight in your face. The high efficiency particle filters, or the HEPA filters, have a minimal 99.97 efficiency rating for removing particles greater than or equal to 0.3 microns in diameter. And what we talk about a lot today is this ULPA filter, or ultra low particle air filters, which have a minimal efficiency, minimal 99.999% efficiency rating for removing particles greater or equal to 0.12 microns in diameter. So in general, for all open laparoscopic endoscopic procedures, a multifaceted approach should be used. Proper room filtration and ventilation, appropriate personal protective equipment, smoke evacuation devices with a suction and filtration system should be utilized. And I'm gonna now turn it over to Eugene. Eugene's gonna, if you can take over the slides. And then Eugene, if you can unmute yourself and you're ready to go there.
Thank you, Dr. McCamey. Do I have control here?
Yes, you do now. Yeah.
Thank you. I'm just going to add a few points real quick to what Dr. McCamey covered. Part of the idea with the N95 mask is, although the porosity of it is larger than ideal, it's splayed in multiple layers of filaments. So the idea is that you are assuming two things with an N95 protective mask. One, that you have water droplets, which are considerably bigger than the virus particles themselves, upon which the virus particles are riding, and that you want to filter out that size, the virus particles and the water droplets, not just the virus size alone. The other concept with N95 masks is that it relies on the idea that if you have aerosolized virus particles not attached to water droplets, that they are moving with a sort of Brownian motion and not a lot of velocity. So they meet the first layer of the N95, they may find their way through that filament, but then they meet a second layer, and they have to sort of wind their way through multiple layers of filament to get through an N95 mask. But that's why an N95 mask that's been used once should not be considered to be, even if you weren't anywhere near a patient, should not be considered to be as good as new. The situation where you have a laparoscopic insufflator and tubing is a much higher pressure situation. That's why the tubings, the filters we're recommending here and all the manufacturers use are the ULPA filter, the much smaller 99.99% filtration. That's because you're talking about now particles that are being driven under extreme pressure. So moving on to the screen, this slide is actually available on the SADA's website, and that document, of course, is sort of a living document in that as more information becomes available, it will be updated. The thing to notice on this particular large screen, or large overall look, is that there is one of these systems, the Cooper system, is a passive system. You've probably seen it. There's a similar system model from Buffalo Filters that I have a picture of next for you that you can look at. But essentially, it's independent of any of the insufflating or other smoke evacuation devices. It's just a tube that connects to a spare port and ends in a round-shaped filter device that then evacuates through the filter into the atmosphere of the room. If we move on to the next slide, there are some footnotes that are also available on the SADA's website, which I'd refer you to for more detail. But essentially, overall, all of these smoke evacuators' main function is to improve vision, including the including the one system that was on the previous slide here that does not have an ULPA filter. I can't go backwards, but if you look on the slide there, you'll see one of those systems, which we'll cover in a subsequent slide, does not have an ULPA filter, and that's the Olympus UHI-4. So we'll cover that in an upcoming slide, but basically that's the main function. The reason that doesn't have one is the main function is to improve your vision by clearing smoke away. In order to have protection of these high velocity particles under laparoscopic pressure, we're recommending that you use a smoke evacuator that has an ULPA filter, and just about every system does have that. There was a question on the chat about which system is best. Honestly, as long as it has an ULPA filter, it's going to be adequate for this purpose. We've discussed with the CONMED personnel, sorry, back one slide. We've discussed with the CONMED personnel the use of air seal mode. If you're places like mine, we have a variety of different systems, one of which is a CONMED air seal. It's supposed to be dedicated for the robotic room only, but young enterprising surgeons may, in this COVID-19 era, may think, well, what about that air seal thing? Isn't that something I could maybe use to increase my chances of not contaminating the room? And from CONMED's description and their letter, which is also linked on the SAGES website, they are not recommending that surgeons not very familiar with that system use air seal in air seal mode. The air seal system actually has 3 different modes it can be used in, only one of which is air seal. If you're not familiar with the device, it involves rapid velocity air being pushed across the top of or in between 2 layers of the port. There's no actual physical valve there. This is not immune to gas spillage. When you insert an instrument, gas can spill out. When you remove an instrument, gas can spill out. And also, just as a side note, mention that many of the laparoscopic instruments we use, especially some of the older devices, have cleaning ports that are often not airtight, or in some cases, the design of the instruments allows gas to come out from between the seams in the device. So these are things that if you can avoid using those older instruments or place adhesive controls or adhesive seals on top of any cleaning ports that you don't have the proper cap for, that would help. So you can overcome that either by using the air seal device in smoke evacuator mode, and in that mode, you do not use any of the actual air seal ports, using their tri-ports instead, which do have built-in ULPA filters. You can also do what you can do for the other devices as well, just include an inline filter. For the Ethicon models in that chart, the only thing you point out is that the Megavac Plus is the only one of those that actually is a smoke evacuator. There we go. This is the plume away smoke evacuator device. It's basically just a passive air clearance filter. There's the big filter in the round section, and you plug the Luer lock device there into a standard port, and it evacuates under the pressure of the insufflation in the abdomen. Similarly, Buffalo filter offers inline filters as well as kind of a plume away filter there. You see that in the right upper corner there. Buffalo filter also has independent separate suction devices that have built-in filters as well. The Nebula filter here, another option. We're obviously not going to be making recommendations under the presumption that you don't already have a filter system in place or a smoke evacuation system in place. And if you do have a system and you have questions about it, the best way to make sure you optimize the use of it will be to contact your local representative for that company. This is the Olympus system, and their solution to the fact that it's not got a built-in filter is to either add a Buffalo inline filter that we covered above, or a passive smoke evacuator onto another port. And this is the Stryker Pneumoclear system. This also has the appropriate filter. It does require proprietary tubing. And lastly, the RapidVac. There's an additional link on the SAGES website pointing to an ultravision device which actually ionizes and causes particles to precipitate out and fall into the abdominal cavity. And you may want to take a look at that as well. This slide is from the CONMED air seal system, and describes how to set up in different modes. We'd recommend that you work with your CONMED representatives should you decide to use an air seal system. Their statement does not exclude use of the air seal mode, but recommends that inexperienced or new surgeons to the system do not try to use this in air seal mode and instead use the smoke evacuator mode.
Okay, and I think that's it. I'm going to stop sharing the screen here.
We have time for a couple of questions. So I know you just went over it, but there have been a few questions, and we just need you to clarify specifically with the CONMED devices. How are you recommending you use them?
Rob, you actually use those? That's not the norm in my hospital.
Yeah, so I actually use those and everything. So, if you're not very experienced with the valveless air seal ports, there is actually no valve to prevent CO2 gas to leak out. They use an air shield to prevent gas to leak out. So you need a special tri-lumen tube to use that. That does have an ultra filter on it. But we recommend that if you're not an expert user, just to use the standard smoke evacuation tubing that has the blue and the clear tubing on it. You put your insufflator tubing on a port and the blue or the purple tubing on the evacuation port, and then that's probably the safest way versus using the tri-valve valveless air seal port.
Yes, I would agree with that. So dual tubing's okay to conventional valved ports or common valved ports on the smoke evacuation mode.
All right, yeah.
In the interest of time, we are going to keep moving on. Again, these questions, of which we're getting many, are going to be posted on the SAGES website in the next couple of days as an FAQ. So keep your eye out on that. For the next talk, we have N95 mask use, reuse, and decontamination. Presenting is Dr. Viola Huang of the Department of Surgery at Stony Brook University in New York. She's also an American College of Surgeon General Surgery Fellow. That's Master in General Surgery Fellow. We're very appreciative of Viola. She's done quite a bit of research in the area of N95 masks. And myself, Sean Suda, I'm from Las Vegas, Nevada, and chair of the SAGES Technology and Value Assessment Committee. So I will begin this presentation. We call this the N95 Enigma because there's been a lot of questions about this. It's not perfect, N95 mask, but it's one of the best things that we have. Many of us haven't placed the mask on our face since our hospital orientation. That's why OR Barbie here says we'll find out real quick who lied about their N95 fit just to get out of there quickly. The N95 respirator is the most common of 7 types of particular filtering face piece respirators regulated by the National Institute of Occupational Safety and Health. It's called 95 because it filters 95% of aerosol particles. As we mentioned, the median is 0.3 microns. It's not resistant to oil. 3M is the most common manufacturer for N95, but there are many different versions. I encourage you to check cdc.gov for a list of approved surgical N95 respirators. Just go to the CDC website and type in N95 in their search bar. They have a lot of good resources there. Sorry, Viola, I got it. Notice that this mask has a one-way valve. So this is an N95 that's typically used in construction. It protects the wearer, but not others. You can breathe through that valve. You can cough through it. This should not be worn in the healthcare setting. This type of mask is not FDA or NIOSH approved for use in the surgical suite. How do you tell if you have a real mask? Well, there will be markings on them. At the top of the mask, there should be a testing and certification number. Sorry, Viola, can you, there you go. On the right is a model number, a lot number in the bottom right. On the very bottom is a designation for what type of mask it is. There should be a NIOSH logo on the left hand, but that can be counterfeited. And then on the left side should be the trademark or name of the distributor or manufacturer of this particular mask. So if you don't see all of these, or at least most of these markings, you may not have an actual NIOSH approved mask. These are examples of counterfeit N95s on the left. Notice there's no markings on this mask. This is not a legitimate mask. In the middle, you have one that says an N95 approved for children or kids. They don't approve any type of respiratory protection for kids, so this is also counterfeit. And on the right, also you see no markings and you see one of these one-way valves, just like the one in the middle. So these would not be appropriate for the surgical suite. And with that, I'm going to pass this off to Dr. Huang.
Sorry, can you guys see it?
Yep, and we can hear you.
Okay, you guys, can you guys hear me now?
Yes, we can.
Okay, sorry about that, some technical difficulties. So thanks, Sean. So basically N95s are designed to just be used one time, but because of shortages, we've had to make some compromises, and there have been a lot of strategies suggested, which is why it seems like it's an overwhelming amount of possibilities. But the CDC has done a lot of extensive work on this, and they have approved some different methods, which I'm going to review with you today as things you can consider. So first off, you can do extended use, meaning that you can use it between patients and you can use it for the whole day, take it off to take some breaks. But overall, they've kind of loosened things a little bit so that you don't have to use a new one in between patients. There are reuse and decontamination strategies, which I'll review with you, but they're not officially endorsed. A lot of them are kind of emergency use authorized at this point, but the CDC does kind of tell us to exercise caution when using these methods. The other important things to note is that the CDC did start saying that you can bring your own masks and own PPE to work, so that's why it's important to understand how to identify counterfeits before you bring those to work. The other thing is expired N95s are allowed to be used because we've heard news about these in the stockpiles, and as long as they were stored properly by manufacturer recommendations, they're still okay to use. So in terms of reuse, the CDC pretty much emphasizes that if you have not been doing aerosolizing procedures, it's okay to reuse it. They also don't encourage you to reuse it if you've been having extended contact with a COVID positive patient. But overall, if you're going to reuse it, you have to make sure that you don and doff it properly, you don't contaminate yourself during this, and that you store it properly, because it does have to fully dry in between. And I'll talk a little bit more about that. But basically, if the virus can't survive for more than 3 days on this material, so if you store it and let it dry for more than 3 days, it's safer. You also don't want it to get soiled, because that can also cause the viral load to be increased. So each time you reuse it, you have to make sure that the seal is still intact. So there are nice videos online from OSHA that talk about how to do this. So a lot of it is making sure that you don't feel air coming around the mask, and also making sure that you have negative pressure when you're breathing in and positive pressure when you're breathing out. They also recommend that if you're going to reuse it, make sure you have a face shield and a surgical mask over it. So the simplest strategy that a lot of people that have been using is actually having multiple N95s, letting each one dry for at least 3 days, and then redonning it, making sure that you're not touching the inside or the outside of the mask when you're doing this. The ACS recommends about getting 7 masks and rotating, but everyone has a different number that they use. It might be good to get hangers so that you can hang the elastic straps up. It helps it dry more evenly. And then you can store it into a paper bag when you have it carried around in the hospital. So I got a lot of questions about how long you can reuse it and how many times. And the CDC just updated their website saying that 5 days is the max that they would recommend, or you follow manufacturer guidelines. But again, N95s aren't really designed for reuse, so these are all kind of can change sometimes in the weeks to months that more research is being done. The next strategy that's been very enthusiastically shared online is decontamination. So this is always going to be inferior to having a new mask, but because we want to be able to reuse it and extend the life of an N95, there's a lot of decontamination strategies that have been mentioned, such as UV light or heat, and I'll talk a little bit about them. So the basic principles when you're evaluating what strategy you want to use is that you really have to be able to inactivate the viral load. You can't let the mask be soiled, so we've recommended not wearing makeup, no moisturizer, because if you have sebum or saliva or other bodily fluids that are in the mask, it can actually harbor more of the virus, and the decontamination strategy will be less effective. Whatever strategy you use, you need to make sure the filtration capacity is preserved as much as possible. So you may not have 95%, you may have like 93, but at this point, it may be better than alternatives. And you have to make sure that the mask fits every time after you decontaminate it. So there's a lot of information online. It's hard to find resources on it, but thankfully there's been a great kind of collaboration between the academic and industry called N95 Decon, and they've got people from institutions all around the country who came together over the last month to do a very thorough kind of literature review and their own experiments in their own engineering labs to look at the 3 most common strategies suggested by the CDC, and they have a lot of good data online. There's technical stuff and some summaries, so I would refer people to that for some good guidance. So one of the strategies that first came out when the COVID epidemic started, or pandemic started, was heat. So a lot of people were putting the N95 in their toaster ovens or their air fryers. This is not FDA approved. And I think part of the problem is it's a little bit of a Goldilocks kind of conundrum, because you need to have enough heat to kill the virus but not ruin the mask. And so the data from previous pandemics or epidemics like H1N1 did show that moist heat can kill the virus, but it's not really proven in the current state with SARS-CoV-2. And then the inventor of the N95 filtration media did suggest that you could heat it at 70 degrees C for 30 minutes, but there's no data showing that this actually will kill the SARS-CoV-2 virus. And also it's really hard to maintain a constant temperature that low with anything that you have at home. So it's really not recommended overall because there's no obvious protocol that has been proven for this particular virus. So don't put it in your toaster oven. The next strategy that people have been really excited about is vaporized hydrogen peroxide. So there was just an emergency use authorization released by the FDA in March, saying that even though that at baseline during normal times they wouldn't endorse this, right now, given that we need different ways to re-sterilize the masks, they're okay with people doing it. So there's 2 major companies that are kind of more approved at this point. One is Batal. They collect a lot of masks and can sterilize it at their facility. And apparently it can be done for up to 20 cycles without compromising the fit of the mask and properly killing the virus. And then Sterid, which is exciting, is good for 2 cycles. And people have been really kind of looking forward to how this turns out, because this is available in a lot of hospitals. So they have published protocols online. I don't personally know of people who have done this, but if any of the panelists know, that would be great to learn more about. But basically, vaporized hydrogen peroxide is, I think, one of the kind of more widely used strategies now. The next one is UV light. So UV light was very popular in the media, I think, during the last month, because a lot of people thought that they could, buy their UV light off of Amazon and sterilize their N95 masks at home. But it requires a very precise dosing protocol. So if you overdose it, you'll ruin the mask. But if you underdose it, you won't kill the virus. So it's not recommended to do it at home. And I know that there's places such as the University of Nebraska and other places that have kind of put data and protocols out, and they've been using it for their staff, and it seems like it's been okay. But just emphasizing that if UV light is being done, it needs to be kind of using some of the data that's already been published by some of these other institutions. So those are the 3 methods that the CDC on their website kind of promotes a little bit more. And they do mention that there's some ongoing research work on kind of autoclaving or steam, but right now those aren't recommended. So these are a list of all the things that we've seen online or had questions about. Again, if you put your mask in the microwave, it will melt and it can be dangerous and will ruin the fit. So I would not do that. And you can see the list of what not to do. So I think the big picture is that we have to protect ourselves, and it is frustrating that there aren't enough N95s, but given that we have these methods available, you just have to judge what works best for you in terms of the context of where you're working, what you're exposed to, and then what's available. So ideally, each mask could only be used once. If you are going to reuse it, use it for 5 days maximum. Make sure you don't touch the inside or outside of the mask when using it. And then when you do the decontamination, just remember that a lot of the data was done on bacteriophages, bacteria, spores, and H1N1, and not specifically SARS-CoV-2. So, you know, we're kind of making these, people are using these strategies based on previous data from different organisms. And also different N95s actually do better with different methods. So I've seen that autoclaving is actually better, is okay for the duckbill 1870, but not with, but it doesn't, the 1870 doesn't do well with like the vaporized hydrogen peroxide. So depending on what masks are available to you, it's gonna change what you can do. And also just remember that there's so many variables that are hard to control that you have to use decontamination with caution. If we have a little time, there are some questions that I've gotten from a lot of people about different things they've thought about for N95s. So air, gas and vapors are smaller than 0.3 micron, so they'll get through. So if you're doing a abdominal case where there's poop or there's other kind of odors, it's gonna go through your mask. It doesn't mean it's not working. It just, those can get through. Sometimes if your glasses fog up, it's actually okay because it's not, your fit is still fine. It's just that the air kind of flows through, and it's not, you still have to do a user seal check, but it can be okay. Also, in terms of if you get really sweaty, there's not a lot of data on this, but I think that if it does get kind of wet with sweat, you probably can't use it for as many times because it does affect kind of the viral load. And then just make sure that when you're donning and doffing that the N95 is the last thing to be taken off. So you have to strategize just like we talked about before with this gloves, like how you're going to do things in order so that you don't contaminate yourself. And then another thing that has come up is a lot of people have been getting rashes and issues on their face, and you can actually put some kind of tegaderms or duoderms to kind of pad different areas of your cheeks without compromising the fit, and you can find some of those strategies online. Thanks.
Thank you, Viola. We have some questions about KN95 masks, which is a Chinese designation for N95 respirators. Previously, in the previous months, those were not approved by the FDA or the CDC, but they are starting to allow some of those through. It's very important that you access the CDC website and the FDA website to make sure that the masks that you are purchasing or using have been approved by one or both of those entities.
Sean?
Yes.
This is Horacio. There is something that I learned today that it may have some potential. I learned it just this afternoon that one of our vascular surgeons on the vascular team have done. Apparently somebody thought about the wrapping for sterilization of instruments, you know, the wrapping where our boxes come out. It's supposed to be ultra-filtrate over 99%. Then UF Gainesville started using the wrap to make masks. And today, this vascular surgeon team with a group of volunteers have delivered over 600 of masks made out of the sterile wrapping. And they are being tested to see if indeed they're going to be as efficient. In theory, and again, this is not confirmed, they could be, if they filter even 4% more than N95 masks. Still to be confirmed, but that's a very novel idea. And it's a material that we discard constantly every time we do surgery.
You know, certainly in this time of crisis, ideally people would use the currently manufactured masks, but we'll come into situations like you mentioned where there is scarcity. And so that's a great thing for us to keep our mind on. Thank you, Dr. Asbin. My institution gave me one mask that I'm, you know, cradling. So this can be a real issue for people. Viola, do you have any comment?
Not really. I did see that people are also using HEPA filters to make masks. So there's a YouTube video that's been shared over 500 million times online from an ER doctor where his wife is making masks for them to wear. So if that's an alternative that is kind of proven to work, then it's better than nothing, I think.
We do have to be nimble. In the coming days, check back on the SAGES website. We will be making a repository for masks that have been approved by our government entities, as well as other products relative to smoke evacuation and filtration. With that, I think we'll move on to our next talk, Critical Care and Mechanical Ventilation Primer. Presenting is Dr. Robert Lim, Vice Chair of Education in the Residency Program at Oklahoma University School of Medicine, Chair of the SAGES Acute Care Committee. And Dr. Michael Cripps, Director of Clinical Research and Program Director of the Critical Care Fellowship at the University of Texas Southwestern Medical Center in Dallas, and co-chair of the SAGES Acute Care Committee. Doctors Cripps and Lim.
All right, good afternoon, everyone. So we're gonna try to spend 10 minutes to get through 1 year of a surgical critical care fellowship. So buckle up. I suppose, Rob, can you give me? All right, so one of the problems with COVID is not just the large volume of patients that are coming to the hospitals and overwhelming the hospitals, it's the fact that so many of them need pulmonary support because of the ARDS. And this, along with the PPE and the ventilators, we're also having a shortage of just the physicians who can manage these ventilators. So one of the things, next slide, Rob, that SAGES has talked about is the fact that general surgeons are uniquely prepared to be able to step back up and manage ventilators. Throughout our residency, we've done critical care training, we've managed ventilators. Throughout our practice, almost no matter what practice you are in, you've taken care of a really sick patient, so you're familiar with the ventilator. So with that, we decided to go over a primer on how to manage ventilators so that if you find yourself in a situation where you're called upon to help manage ventilated patients, you have this reminder, a primer to get yourself going again. And with that, I'll turn over to Rob to start us off.
Thanks. So first, I'm just going over the indications for mechanical ventilation. And basically, it's to maintain a patent airway first and foremost, right? If they're intoxicated or there's some trauma to the airway, specifically the oropharynx, then yes, you want to intubate. Other causes would be acute respiratory failure from other problems like sepsis. Compromised lung function, like in pneumonia. This is where the SARS-CoV-2 infection requires intubation. Basically, it overwhelms the lung and compromises the lung function so bad that you need mechanical ventilation. Another indication for mechanical ventilation would be from difficulty breathing. The patient's frail or has fractured ribs or something that they just can't do the oxygenation and ventilation for themselves. Keep it simple is always the rule. You want to get air in and as well as exchange the bad air out. And you want to get it to the blood so that it goes around to feed the tissues. For the most part, the SARS-CoV-2 virus and the COVID-19 disease affects the patient's ability to oxygenate. So using a step-up approach from giving supplemental oxygen to intubation. And when you're doing that supplemental oxygen, you want to use a non-rebreather to decrease the aerosol spread of the virus. You'll hear about later on, but we don't want to typically use CPAP or BiPAP modes, positive pressure that might push the virus around to the other providers and to the rest of the room. So it's either supplemental O2 by a mask like that or go into intubation. And you want to support their oxygenation until their lungs can improve enough. So if they also have concomitant renal failure, then they get dialysis. If they have cardiac dysfunction also, then obviously you want to support that until the lungs can recover. Basically, three main methods of ventilation assistance. One is continuous mechanical ventilation. Here, basically, the ventilator gives the breath to the patient at a preset time, regardless of if the patient overbreathes it or not. Typically, these patients, though, aren't breathing on their own. In the assist control mode, basically, again, it's mechanical ventilation, and it gives it at the preset time, but if the patient breathes over the ventilator, there is some support given for those breaths also. And this is divided up into two modes, the volume controlled mode and the pressure controlled mode. In the volume controlled mode, the ventilator will give the breath at a preset volume, say about 400 mLs, right, to give oxygen and a certain FiO2 into the lungs to deliver the oxygenation. In the pressure controlled mode, that's probably the more common way that we do mechanical ventilation. In the pressure controlled mode, the breath is delivered until a preset pressure. So the machine will keep giving oxygen and the pressure until a certain pressure is met, not a certain volume. So this may be more than what we expect because the lungs are more elastic, or it may be less because the lungs are less compliant. This is the mode we use to try to prevent barotrauma. In pressure support ventilation, basically the patient needs a protected airway and needs some assistance in breathing. They're just not strong enough. So this will help push air in, but it's usually typically not with an added FiO2. And the patient is breathing at their own rate. So the machine does not breathe over them if they don't take a breath. The things that we can control on the ventilator, the respiratory rate, and you see the normal values there. The respiratory rate and tidal volume basically control your ventilation, which Dr. Cripps will talk about. Your oxygenation and positive and expiratory pressure will control your oxygenation, which I'll talk about a little bit more. To improve your oxygenation, you can increase your positive and expiratory pressure. And the reason why this works is because more pressure down to the alveoli, it improves the oxygen exchange by increasing the functional capacity of the lungs. Normally, we add on about 5 to 20 millimeters of mercury to do this. You can also increase the FiO2. This is the percent of oxygen within the breath that you're giving. Normal, again, is about 20, 21. That's normal air, but it can go all the way up to 100%. The goal is to get a saturation of about 93 to 96%. Or in patients who have already previous compromised lung function, like from COPD, your goal is 88 to 92%. Again, COVID-19 disease is mostly from poor oxygenation. How do we do this? Well, basically, when you intubate somebody, you start at 100% and you start to dial it down, aiming for a PaO2 of about 60, and that's on your ABG. Again, your saturation about 88%, especially if they have previous lung disease. Ultimately, you'd like to get an FiO2 less than 60%, and then decrease by increments of 10% each time to get down there. So if patient's doing well at 100%, you wouldn't go on, and they have a PaO2 of say 75, you wouldn't go down to 60% or FiO2 right away. You'd step it down by 10. A couple notes: cellular injury can occur and death through oxygen-free radicals. So you don't want to keep them at 100% all the time. An absorptive atelectasis through alveolar nitrogen washout also can occur. Regarding positive and expiratory pressure, the amount of pressure at the end of the expiration helps keep the alveoli open again. For exchange, most times we start about 5. If the patients are obese, we usually add a couple of points of PEEP, so they usually start at 7 or 8. This helps minimize atelectasis, so there's less shunting of blood away from the oxygenated, blood away from the oxygenated alveoli, which is why it works to help increase oxygenation. Usually go up by increments of 2 or 3, depending on the status. If you get up to about greater than 15, then at this point, if you're not used to using ventilators, you may just want to start seeking help from your critical care colleagues. High levels of PEEP can affect cardiac output, and it can reduce venous return by simply compressing upon the vena cava, and therefore reducing cardiac output. It can prevent the heart from expanding as much as it normally could also, and it can cause a pneumothorax, which of course would compromise both your lung and your cardiac function. This is straight from ARSNet, which you can look up online, and you can download a little card. This basically is talking about titrating your PEEP and your FiO2 together. You want to do it sort of in increments, and you can see by the tables, you might go up on your FiO2 first, but stay with your PEEP, and then you follow along in this table, as well as going down the other way. Using higher, or excuse me, not going down, but using higher PEEP and lower FiO2. Either one of the methods is fine, but just try and follow that that scale when you're doing it. All right, I'm going to turn it back over to Dr. Cripps so he can talk about ventilation.
All right, so thanks, Rob. So as oxygen concentration and PEEP control oxygenation, respiratory rate, tidal volume control your ventilation. All right, so for normal respiratory rate, Rob, can you kick next slide? So respiratory rate is how we use to control the CO2 if that's necessary. Really what I want people to focus on if you're in this situation is not necessarily the CO2, but it's going to be the pH. And we'll talk about the permissive hypercapnia a little bit later. For respiratory rate, I typically look at the pre-intubation respiratory rate, and I'm going to dial the vent to just a little bit below that. And remember, that's going to be their guaranteed respiratory rate on their ventilator. So whatever you dial it in, they're going to be guaranteed to get those number of breaths. Next slide.
Sorry, Mike, hold on.
You can do next slide. It's not clicking over for me. So tidal volume is the other modality we use. So we want to, that's how much volume the patient's going to get. So we want to aim for about 6 mLs per kilo of ideal body weight, which is going to be different for males or females. There may be some of the crowd that remember doing this when it was 10 to 12 mLs per kilo, but we know the data is pretty clear that we want to have a lower tidal volume because it decreases lung injury and improves survival. So pragmatically how we do this, so if a patient has respiratory acidosis or hypercapnia, you can increase the respiratory rate. Not uncommon for these patients to be up in the mid-20s, low 30s sometimes. Managing the tidal volume depends on which setting you use. As Rob said, for these patients, we typically are going to use a volume control ventilation. So you're just going to set it at 4 to 8 mLs per kilo and watch the pressure variation. The pressure variation is important here on ARDS patients because prolonged plateau pressures above 30 can cause some barotrauma and affect the oxygenation and gas exchange. So that's the number you want to tinker with when you're changing the volume around. And this is all because ARDS patients have a significant decrease in their compliance, which is to say they have really stiff lungs. A lot of patients at risk for COVID are COPD patients. We're a special category. They're hard to ventilate without COVID. One thing to keep in mind is if you think about how a COPD patient breathes, they have a very long exhalation. So you may need to tinker with the expiratory ratio there and just increase that, which all it says is you're going to increase the amount of time the patient spends in expiration phase. Permissive hypercapnia, what's that to say is that when you're looking at your ABGs, I don't really care what the CO2 is as long as the pH is above 7.2. If it starts to get to 7.2 or a little bit less, then you can start trying to blow off some of the CO2. Again, in the COPD patients, be careful because in doing that, you can start breath stacking. So be very cognizant of your IDE ratio in those folks. All right, so after you initiate ventilation, you're going to get a chest x-ray. Don't be surprised if it looks like this. This is what the majority of these patients are going to have on their chest x-ray. Check their vital signs, make sure you didn't drop their pressure, look at their pulse ox to see how their sats are doing. I check an ABG after 30 minutes every time I manipulate the vent, and then I adjust accordingly. All right, so if this doesn't work and you're having problems oxygenating your patient, seek help if you have some. If not, the first thing I'd probably do is start looking towards paralysis. This is definitely going to help with plateau pressures and oxygenation. It's an easy one you can start on your own. Prone ventilation, now it's going to be a little bit trickier and it's going to be harder on your nurses, but it's definitely going to help out with your, well, not definitely, but it could probably help out with your oxygenation. And then if that's still not helping, site dependent, you might start seeking an ECMO evaluation at this time. All right, real quick through the critical care, all these patients need a central line, use a PICC if possible. They need an A-line, G-tube, Foley catheter. For a sedation, check what your pharmacy has and what their protocols are. Otherwise, if it's okay to go with propofol, it's very easy to use. Start at 20 mics per kilo per minute. Watch for hypotension. Also watch for triglycerides if you're leaving them prolonged on propofol. Check every 3 days. Hold if it gets over 800 milligrams per deciliter. For pain, I like a fentanyl drip. I started at 20 mics per kilo. It's also very good for vent desynchrony. So if you have a patient that's bucking the vent, you can go up on the fentanyl, and that's very helpful for that. A lot of these patients do have renal failure. So if that is occurring, be cognizant you're going to have to adjust for renal clearance. If the patient does get hypotensive, we haven't seen that a lot in our COVID patients. So first check your sedatives. Don't fully wake up the patient though, because you can lose some ground on that. Be conservative on your volume. Crystalloids are preferred over colloids, all that's weak evidence from SCCM. Be cognizant that they can get a bacterial superinfection, so watch out for sepsis. If these aren't working, they're still hypotensive. Levophed is going to be your preferred first agent, then followed by vasopressin in addition. If that's not working, then go to epi after that. All right, if you do, or if you are called upon to extubate one of these patients, obviously make sure that they're saturating fine, not on an FiO2 of more than 40%, not on a lot of PEEP. If you want to check your RISB, which is your respiratory rate divided by tidal volume, that should be less than 105, and definitely make sure your PF ratio has improved. Not just to say that they've improved from their lung injury. Probably not a good idea to extubate to CPAP or BiPAP unless they're a COPD patient or used to it beforehand. Next. All right, so this is just the last slide. So my advice for all critical care and any emergencies, don't just do something, stand there. Think about what you're doing, okay? Work through the problem. COVID-19 is primarily an oxygenation problem. Work that first, okay? Then go from there. If you are called to manage event, you're in dire straits, you're doing a good job. Think about that. Lots of other resources for guidance. sccm.org, COVID-19 has some great simulators to go through. And that's it for our time. Thanks.
Thank you, Michael. Real quick, with either you two or anybody on the panel, do you find your decisions to do tracheostomy on patients changing at all?
100%. Yeah, we are not going to proceed with the tracheostomy on these patients right now. A lot of these patients right now are remaining intubated for several days, but not to the time frame that we think is going to necessitate a trach. So at that point, with the risk of the aerosolization in the area, we're just going to leave them intubated for the time being.
Thank you.
Yeah, I agree with that. If they survive and they get to that point where they might need a tracheostomy, then I think the guidelines are going to be coming out about that shortly. But I certainly wouldn't do anything urgently based on the data that people do better with earlier trachs. That doesn't count for this particular situation.
Yeah, that data is typically oriented around people with traumatic brain injuries going to have prolonged ventilation timeframes. These patients have a rapid onset of ARDS, and if you can get them through that initial phase to that post-ARDS period, we're able to extubate them.
Thank you. We're running a little long, but we have a topic coming up that's very important to people who are practicing right now, and that's telehealth. To present this will be Dr. Kevin Waskell, partner of Surgical Associates in Neenah, Wisconsin at Theta Care Hospital System. He's a SAGES CPT representative and co-chair of the Community Practice Committee. And Dr. Caitlin Halbert of the Department of General Surgery at Christiana Care Health System in Wilmington, Delaware, and chair of the SAGES Community Practice Committee. Drs. Halbert and Waskell.
Hi, thank you very much for the introduction. Kevin and I are excited to switch from critical care to this big jump here. And I appreciate the opportunity to talk on this tonight and an excuse to wash my hair. So excellent. We're going to talk about telehealth basics because for a lot of us, telehealth wasn't something that we did in our daily practice. And as a little bit of a silver lining, I think that this is something that we can all learn during this. We've got some time to do it, and we could potentially use this moving forward. So this is a good time to learn. So what is it? What is telemedicine? Telemedicine is a two-way interactive communication using an audio-visual system in real live time. Everyone on this call tonight has already taken step one and learned how to log on to a Zoom account. So this is step one. You've done it. And who can do it? So really any healthcare provider right now, physicians, PAs, NPs, psychologists, dietitians, social workers, all can participate in telehealth. We even have our residents doing some of these with attending oversight. So has been, a lot of people can utilize this in their daily practice. Is it safe? Now, we're probably gonna get a lot of literature coming out about this. There was just a couple weeks ago published in the American Journal of Surgery, a randomized controlled trial looking at follow-up visits for surgical patients. There aren't a lot of other studies looking at it in surgery, but we know from other subspecialties that it is relatively safe. Usually it's in the follow-up type of environment where you've already have an established care with those patients. But we're starting to see now using this for new consultations and not established patients. So we're going to be seeing some more about whether or not this is truly safe. But for the most part, it really is up to the surgeon, up to the practitioner, what you feel safe doing over the phone and what you don't. How do you do this? So this is actually my setup at home, although my institution actually just gave me a larger monitor. And the larger monitor helps me see my patients a little bit better. So I use Zoom personally, but there are a lot of different programs out there. Microsoft Teams, there is, just a plethora. We have them listed in our telehealth primer that you'll get the link for shortly. And there are also a lot of non-HIPAA compliant technology systems out there, so be aware. Right now, they're allowing those non-HIPAA compliant systems to be used, but really you want to start focusing your institution, your practice on a HIPAA compliant technology that do come at a cost, of course. So like I said, we use Zoom, and I got a new monitor that's bigger. One easy solution to using a small laptop like I have right here in the picture is I have, like, for example, an iMac at home, and you can get cords to double screen or mirror screen your laptop so you can see the patient a little bit better. You can also then split screen so that you can see the patient on the bigger monitor and you can be working on your note on your laptop, or if you split the screen. You can, for most people actually, your work computer should, and often does, have a webcam and a speaker with a microphone. And usually those are really good. Now, if you don't have a really good webcam, you can actually purchase a webcam on Amazon for about $100. This is a Microsoft HD webcam that I use and travel with on occasion. Obviously, I'm not using it tonight because my iMac is providing that information. And then the other thing you can purchase is a headset. So if you're at home, kids are playing in the background, dogs barking, this is a great way to isolate your voice and hear more, a little bit better with the patient. So a headset is a nice addition too, a couple bucks on Amazon. So if you really want to get fancy, you can use a ring light. And I actually have a ring light on right now that I'm utilizing. This is what I would look like without it. This is with it. It just allows the patient to see a little bit better. If you're in daylight, it actually darkens you, so they may not be able to see very well. So the ring light actually lets me take my telehealth anywhere I want and not have to worry about lighting. It's a little trick, but it's nice. And then the other thing is a green screen, a physical green screen. I don't actually have one today, and you can see that when I move, it's not as clear and it's a little fuzzy with my backdrop. A green screen would eliminate that. So that is helpful if you don't want your patients to know that you are in your closet, attic, basement, bathroom, wherever you happen to do your telehealth. And those can also be purchased over Amazon. Okay, so that's your setup. So how do you complete the documentation? So you're going to go through your visit with your patient. You can even do a pseudo physical exam because you can ask them, my patients show me their incisions so I can see them, make sure there's no redness, drainage, things like that. And then you're going to be doing your documentation. So how do you do that documentation? The first 4 things here are the most important when we're talking about telehealth. And the 5th one is a no-brainer for hopefully most people on this call tonight, because we obviously do our documentation to support appropriate coding already. So we want our statement that the service was provided via health. We need that in there, and we need to also write in there whether or not we use HIPAA compliant technology, what kind of technology we did use. We want to know the location. Where you are is somewhat not that important, but where your patient is really important, because you need to be licensed in the location of where your patient is. We'll get to that in just a minute. So you want to say where the patient is located. We want to know the roles. That's usually pretty clearly understood in your documentation. And you want to put that informed consent in there. Now, the question about informed consent, whether it needs to be a verbal or written, that is important. Usually you've already established care with a patient in person. They have signed a written consent that says that, yes, I'm willing to go ahead with telehealth. But if you haven't established them in person, they may not have that opportunity. For right now, we're waiving that. By we, not me, like this is CMS and commercial insurers and institutions, that you actually can do that consent verbally, but you do want that documented. So this is what I use. I'm going to just bring the whole thing up. I'm not going to read through this, but for those of you that are on the group tonight, just screenshot this. This is an example of what the consent looks like, what the telehealth explanation looks like. So this is just a quick screen grab with your phone, and we'll move on. Okay, licensure and coverage. So before the current pandemic, you needed to be licensed in the state where the patient is. So that's where you're practicing, is where your patient is located. To the right of the screen here is the IMLC, the Interstate Medical License Compact. So of course, Delaware, where I'm from, does not part of this, but 29 other states, DC and Guam, are included in this. And so what that means is if you get licensed in one of those states, then you can also go on to become licensed in all the other states. So for right now, I have, for example, 6 different state licenses because I do a lot of telehealth. I have a destination program. And so it is costly, it is time consuming to not only get those state licenses, but maintain them. So this is the solution to that. This had come out of really the people that are trying to do telehealth. And so take a look at their website. You just type in IMLC, it will come up. This is growing. I know that I'm working with my institution, because Delaware is not on this, to push forward legislation to bring IMLC Compact to Delaware. And of course, big states like California, Texas, New York, they are not on this. So, so please, this is a great time to talk to your states about bringing legislation for this forward. Historically, the coverage for telehealth was only granted to patients in rural or remote locations. However, those patients, in order to receive telehealth visits, they must have been in a clinic, hospital, or other medical facility, so they couldn't be at home. Other recent expansions that happened, this was just in the last year, there was expanded virtual check-in coverage that if the patient initiated a conversation virtually with the healthcare provider, you could actually get that covered. And then also the e-visits became covered under Medicare Part B, and this is another type of non-face-to-face communication. So we're going to give you a lot of resources because things are obviously changing. The FSMB is putting out updates on state waivers that are coming out now because of the pandemic, okay? So this is where we are going to be looking at licensure during the pandemic that allows some flexibility in where you can practice medicine. And this is essentially across state lines. You don't want to look at your own state because ideally, hopefully you're already licensed in your own state. However, if you have a patient across state lines, you want to know what that state waiver is saying, you can log on to FSMB and they can give you an update on this as well. Right now we have 25 with waivers and about 26 without. So, and it's growing. This is 2 days ago, so it's probably changed since then. And also during the pandemic, so these are some of the major changes. I'm gonna then turn it over to Kevin here. But the 1135 waiver is the big change that came in early March. This allowed Medicare flexibility for telehealth visits. This allowed basically for us to provide healthcare, telehealth care in the home. And this would also allow coverage. We could be able to bill for this and receive payments at the same rate as an in-person visit. Again, that is contingent on proper documentation. And the Department of Health and Human Services will not conduct audits during the pandemic because of these expansions. Medicaid is state dependent, so you need to follow up on your states and what kind of flexibility they are going to have during the pandemic. This is changing rapidly. And private payers, as they always do, are going to follow suit with CMS. Now, some of these changes overall here on this screen may change permanently. Some of them will go back to pre-pandemic restrictions. So keep an eye on that as things evolve. And then Kevin, I'm going to turn it over to you. Do you want to take control of the slides?
Thank you, Caitlin. All right. Well, this is a summary of the bullet points that are key. I've been on CPT for a long time, and this is still complicated for me and changing on a daily basis. But basically, these are the key points to remember what's changed right now and where we are at this point. Medicare will pay for physicians for telehealth services at the same rate as in-person visits for each individual diagnosis. Patients can receive telehealth services in all areas of the country, even at home, which is a big step, as Caitlin alluded to. CMS list of eligible services expanded, Now, the private insurances and the state list have not expanded as fast, but they're getting there. CMS permits reporting on telehealth for office and outpatient visits based on time and also E&M management. Some states and insurances are also starting to follow this. The list of qualified health professionals is also expanded, which helps in terms of people that have bariatric groups and things like that have multiple different types of people involved. Caitlin, can you advance this? Telehealth services are now permitted with both new and established patients. This was confusing at the beginning. Physicians can reduce or waive cost sharing. A number of the private insurances have started allowing for the waiving of the initial upfront fees, which kept people from proceeding with our willingness to proceed with this kind of telehealth. Physicians licensed in one state can provide services to Medicare patients in another state that Caitlin already went through. The HSS has relaxed the regulations as we talked about, but it's still a good idea. And Caitlin emphasized it, but I can't emphasize enough that if you're going to make a commitment, consider if it's available for you, consider technologies that are HIPAA compatible at this time. The qualified healthcare professional you'll hear listed on a lot of these different papers would be most likely physician, nurse practitioner, and physician assistant. The qualified non-physician would be dietitian, speech pathologist, PT/OT, social workers, psychologists, and others. But this is also changing. All right, next slide. So this is the next slide you can go to. I'm going to go through a couple of the simple coding elements that are out there. First of all, there's digital visits. This is kind of with the check-in that Caitlin alluded to that was approved in 2019. There's a virtual check-in that really is made for a quick 5-minute check and it is really not the true telephone that we're using a lot now. This can come in two different ways: with the telephone with a virtual check, or an online visit through a portal in the EHR or in a secured email. And you can see the codes here. I'm not going to list these, but these will be happy to discuss further offline and in the at the SAGES website after. Next slide, please. The telephone visit, a lot of people are using now. It's not well reimbursed. It's by the physician. It can be a new or established patient. It can be a COVID-19 or non-COVID-19. Initially, there was some debate about that. The code for this, you should probably be aware of, is 99441 or to 99443. And CPT is always available to look at. You can look at that online and find these different codes. But the key part of this has got some exclusion criteria that you can't have an E&M billing within the last 7 days or in the next 24 hours. It's really only commercial payers at this point in time. This may change, like a lot of this information. It's based on time unless the state orders dictate differently. And prior to the pandemic, it was always a place of service was listed as the physician's office. But this is not as important in this pandemic. Next slide. The telehealth visits, outpatient office visits, is really where we're emphasizing right now. And this is going to spend a little more time on this one. Again, this is physician or qualified health physician, including your nurse practitioner or PA. It's CMS and CPT. It can be with E&M or with time. I encourage you, no matter what you do or whatever document you're putting, to include time in your documentation. CMS and other insurances require a 95 modifier. CPT codes, you would use a 02 modifier. New patients are 9920105, and established patients are 9921215. The key parts about this is with the new patients and the established patients, there is some criteria that as you're going through those from 1 to 5 and from 2 to 1.5 in terms of documentation, in terms of the history and physical examination that we include from basic to comprehensive, from presenting symptom from minor to severe, and from and several elements also keep in mind. But you really have to document those. The objective things are harder right now to be able to get. We can get some pictures with this. We can get, some people have a blood pressure cuff at home. Some people have You can take a look at their incision and those kind of things. So it's really limited in how to get to the more comprehensive elements. So documenting your time will also help you with that. Again, prior to the pandemic, this was listed as a place of services at home, a place of service at the physician's office, which has caused some confusion for the next slide, which is very similar. If you look at this, it's really the same thing, but different numbers for right now during the pandemic, because it's the place of service there is at home. I've got a lot of questions after we did the primer. What's the difference in these two? Really, there is no difference now, because the place of service where Caitlin had previously told you that was usually at a clinic or a medical facility, now is for the patient has changed. So is the place of service where these are coming from in terms of the physician's office or home or a home visit for the patient. So it's a lot is changing. Next slide. So in summary, these are some key points that Caitlin and I both thought were worthwhile. Moving to telehealth is a lot like drinking from fire hose. It can be intimidating, but it is the perfect time. We have a little bit more time to work through some of these things. It is important to develop consent and also to document really clearly. And remember, in your consent, make sure that you include the element of the COVID-19 pandemic. You need to develop a whole new patient flow. We've developed a flow where I can do it from work or at in the office, depending on if you have help that can do the check-ins or not. But there's these flows take a little bit to work through. It can be some hiccups, but they can be really beneficial once you get a good flow. Keep up to date with the national, state, and private insurance changes, and they change on a daily basis. The state ones are really changing rapidly depending on what the individual governors are doing, and also by probably the degree of COVID-19 surge. Be prepared for technological or process issues. I've had a number of them already. It will happen. Have a contingency plan with your patient and make sure that they're aware that that could happen. And it's going to be just a simple call back and get reestablished. And that most patients are really receptive. Your commitment to telehealth will be worth it. Some regulations may return after the pandemic, but it's likely that telehealth is here to stay. And for some of us that are in private practice like this, this has been a lifesaver to learn this right now. So with that, I'll turn it over for questions.
Thank you, Kevin. Great presentation with a lot of information. Before handing off to our president for some final words, I'm going to ask you the $15 question of you and Caitlin. Are you guys collecting money yet? You have to unmute.
Yeah, I can't say that for sure. I guess we'll find out in a couple months. We are billing. We are making sure that we hit all of our documentation that we need. But yeah, it remains to be seen. It's gonna be super dependent on, you know, our commercial insurers, what they're willing to cover, how well CMS does. Again, there won't be any audits, so I don't know how that's gonna play into this. It remains to be seen. But I think that there is a movement to support, especially those in private practice right now, where we're seeing our colleagues, you know, think about shuttering their doors, and so I think there will be some positive movement as far as reimbursement.
Thank you.
I got reimbursement yet, but I think that we're having more and more breakthrough where even our nurse practitioners, our PA students are billing now. So we're hopeful here. We will update people as we hear about that.
Thank you. I want to thank all of our speakers today and for the audience for spending time with us. All registered participants will receive an email to claim their CME credits. Check the SAGE's website over the next few days. We'll have a recorded version of this webinar also for CME credit, and we'll be developing a frequently asked questions and answers for many of the questions we weren't able to get to today. With that, I'm going to pass this off to current SAGE's president, Rashu Asban.
Thank you, Sean. This has been great. It is clear all the effort that it has been placed in creating this webinar. In addition to this webinar and in addition to the COVID-19 page that we have all been working, and hopefully you find it useful, please don't forget to also look at the Facebook groups. There are several Facebook Live lectures, and that is also a way how you can participate. Give us your feedback, tell us what you need, Tell us what other things you think SAGES can help and be able to provide the information and focus the subjects that you want us to concentrate on. I want to thank Sean and all the panelists. Without any doubt, this has been fantastic. I also want to thank Erin and Sally, who are behind the scenes. It's a group that it's always a can-do group. And without them, we couldn't organize this. Jason organizes all of this too, and Ed Rosado. They have been fantastic on being able to help us put this seminar. Now, as this virus affects our personal life and in many different ways, and I mean in many different ways. Tomorrow I'm gonna have to shave because if not, they are not gonna give me an N95 mask. Then it also affects us in our daily work, right? I mean, from us being the ones deciding, now we have to ask permission to take patients to the operating room, giving us less masks. All of that really puts a stress on us that we're not familiarized. But we have to remember we're surgeons. And becoming a president of SAGES has humbled me to see how many people have stepped up to the plate to create all of these documents, to work, to offer, to try to make a difference. And then I thought, well, that shouldn't surprise me. We're surgeons. We are leaders by nature. We actually lead every day, right? I mean, we reassure our patients, we give hope, and we make decisions. Then we need to continue making these decisions in this crisis. We need to step up to the plate. And at the same time, as I said, we give hope to our patients. We should do that too to our colleagues, because this is the time that we all need to have hope. One day all of this will pass, and I know we know that, but I don't think how much is that in our brains every day. Because of the news, because we hear, because of our worries, our fears, we forget that one day this will pass, but it will. It definitely will. And we will be celebrating camaraderie, collegiality, and the art of having good fun as we always do in person. Then don't forget that, and give us feedback about what we do. Stay well. Best wishes to you and to all of yours. Thank you very much, and congratulations for this.
Thank you, everyone.
Thank you.
Thanks, guys. Great job.
Really well done.
Thank you. Have a good night, guys.
Thanks, everyone. Appreciate all your work.
Wonderful job, everybody. Great work. Great presentations.
Maybe see you next week.
Yes.
Same bat time, same bat channel.
Good. I'll wash my hair next week again then. Good.
By then I'll be shaved, Caitlin.
It's that circular light. We all gotta get that.
Yeah, I was going to say that, it affects our personal lives that I have to shave and you have to wash your head, but I thought maybe not. Maybe I shouldn't say that.
Yep, that's how it works. Yeah.
All right, I'm on trauma call, guys. I got to get out of here.
Okay.
See ya.
Great job.
Thanks.
Thanks, everyone. I'm headed out too. Gotta feed the baby.